Thank you to Spark for hosting us. Thank you, Dr. Bishop, for being here together. This is such a fun topic to engage in and learn more about and figure out how to try and navigate when you have colleagues that you really enjoy getting to do it with. So here we go. Medi-What, the role of Medicaid and Medicare for care access among aging autistic adults. We have a few goals for the presentation today. They include describing Medicaid, Medicare, and health insurance for aging autistic adults, perhaps a recommendation to the government to not name health insurance programs. So incredibly similarly, it would help to differentiate Medicaid from Medicare, but may not make for as catchy of a webinar title. Another goal is for us to identify insurance coverage disparities and challenges, and to discuss research to date about how service gaps and eligibility criteria impact health outcomes. We also seek to consider the resources that are needed by autistic individuals and families and care partners to navigate aging and health insurance. So the place in which we explore this topic has got a lot going on. So in the United States, we know that there is a broader context within which the population is also aging, and that we need to focus on strategies for autistic individuals that can build upon the ways that we're looking to improve the infrastructure and insurance access for all aging people. But that means that we need to make sure that we consider what might be unique considerations and pathways for autistic individuals, and making sure that this voice is heard across strategic frameworks and across national planning, and that autism is not lost in these conversations, but has a focus and prioritization. Next slide. We also know that these policy changes matter, that when we can make changes to anything, Medicaid or Medicare, that we often see improvements or potential harm when it leads to disparities, when it leads to reduced access. And that means that we have opportunities to use data from these systems and ways in which we talk to people who are using them to understand better how we can prioritize those changes, what can help us do better the most quickly.
Yeah, I think it's really important for us to think about our topic today within the context of autism's history. So Donald Triplett, who is the first person diagnosed with autism, died at the age of 89 back in 2023. And I think that it's really important to think about aging in autism as a reality that we're just now at the historical point where we can rigorously and comprehensively study aging among autistic people. And I know that Dr. Shea and I are very, very excited to both be doing this work and to be collaborating on trying to better understand aging within the policy context among autistic people. So we've seen over time that there has been significant changes to our diagnostic practices. We've become better at diagnosing autism more sensitively. We've become better at identifying autism. And in reality, this may be leading to some potential cohort effects where the current generation of autistic older adults, and I should also say really quickly that Dr. Shea and I both use identity first language when we're talking about autism, because our advisory boards tend to prefer that we use identity first language. But we are aware that many people have different feelings about identity versus person first language when we're talking about autism. But back to what I was saying related to how cohort effects may lead to differences in the people who we're studying who are aging now versus the people who are currently children or who are maybe in their early 20s who will age as time goes on. The folks who are older now may be different because of these cohort effects and because of changes in diagnostic sensitivity. Yet, we do know that autism is a lifelong condition, and at the current moment, less than 1% of federal research funding has gone to aging research focused on autism. And Dr. Shea and I are both part of the two first Autism Centers of Excellence grants that are focusing on better understanding aging among autistic adults. So the tides are turning. We're hoping to get ahead of the research so we can help develop practical solutions now for people when it matters as they're aging. When we're talking also about aging and autism, we have to keep in mind that there's a services cliff. So when folks on the autism spectrum leave high school, and when folks with intellectual and developmental disabilities in general leave high school, they often experience what we think about as the services cliff, which is essentially the discontinuation of services at the point of high school exit. In adulthood, Medicaid, Medicare, SSI, which we'll talk about a little bit later when we're discussing how you qualify for Medicaid and Medicare, and supplemental SSI is supplemental security income, and then there's Social Security disability insurance, which we'll also talk about in a little bit. And these are some of the only ways that autistic folks' needs are well supported after high school. However, I think as Dr. Shea alluded to, it's really complicated to understand Medicaid and Medicare, and you shouldn't need to have a PhD to be able to understand these vital health service programs that we have in our country. We will be focusing in this presentation specifically on Medicaid and Medicare, but I also just want to mention very quickly that the Affordable Care Act had some really important impacts on healthcare for autistic people, namely that autistic folks can stay on their parents' health insurance until age 26 if they meet eligibility criteria for doing that. It's increased the affordability of health insurance for folks who don't qualify for Medicaid and Medicare through the health insurance marketplace. I think very importantly for autistic people, it reduced the degree to which pre-existing conditions were limiting folks' ability to get insurance or to have different procedures and visits covered by their insurance, and improved access to preventive services. And then in some states, there was a Medicaid expansion, which we'll also talk about in a little bit. So let's talk about insurance types. What are Medicaid and Medicare? So currently about half of the US has health insurance through their employer. About 1 in 5 have insurance through Medicaid, and 14 to 15% of the adult population has health insurance through Medicare. The Affordable Care Act marketplace is covering about 6 to 7% of the US population, and then we still have about 8 to 9% of people in the US who are uninsured. We also have some folks who are covered by military or Veterans Administration or TRICARE insurance. And importantly, autistic people may access their health insurance coverage through any of these means, right? We're just going to be focusing on the autistic people who are covered by Medicaid and or Medicare. So Medicare is a federal health insurance program that is designed to cover folks who are 65 or older, or certain younger people with disabilities, or people with categorical diagnoses that qualify you automatically for Medicaid, like end-stage renal disease or ALS, which is also known as Lou Gehrig's disease. There are different parts of Medicare that cover different types of services. There is hospital insurance, there's medical insurance, which covers outpatient procedures, and then there's also prescription drug coverage. And some folks have all or just one of these different parts of Medicare that are covering their healthcare needs. So if you're under age 65 and you have a disability, how do you qualify for Medicare? So people who qualify for Medicare who are younger with a disability typically have what we call Social Security disability insurance, which is a type of program that is available to folks who have a work history and who have paid Social Security taxes, but have a disability where they meet criteria for not being able to work and therefore qualify for SSDI. They may also have end-stage renal disease, or as I mentioned before, ALS or Lou Gehrig's disease. So currently Medicare is funded by the Social Security Administration or federal taxpayer dollars. Our FICA taxes, so when you look at your tax returns, if you look at the FICA line, those taxes are partially covering Medicare costs for all people who are Medicare beneficiaries in the United States. So, and what is Medicaid? So Medicaid provides free or low-cost health coverage for millions of Americans, including low-income adults, children, pregnant women, elderly adults, and people with disabilities. So importantly, unlike Medicare, which is administered by the federal government, Medicaid is administered by states. according to federal requirements. And this joint funding, essentially, the federal government is providing matching dollars to states for covering Medicare or Medicaid expenses. It's also currently the single largest source of health insurance in the United States. It is what we call means tested, which means that we're looking at how much money an individual makes, and then also how much they have in terms of their assets or savings. And then it's also an entitlement program, which means that all people in the United States who are paying into the tax system can qualify for Medicaid if they meet eligibility criteria. So the federal Medicaid assistant percentage, FMAP, guarantees matching funds to states for qualifying Medicaid expenditures. In the US, states are guaranteed at least $1 in federal funds for every $1 in state spending on their Medicaid program. So importantly, what this means is that if you're in a state that spends less money on the Medicaid program per person that's in Medicaid, they'll be receiving less money from the federal government because it's a matching program. And because of this, Medicaid looks very different from state to state. Eligibility criteria are slightly different from state to state, but follow federal requirements. And then the things that are covered by Medicaid within states do also vary slightly. So for people with disabilities, and this slide is a little bit focused on children, but we're presenting mostly on adults and aging. There are 3 doorways to Medicaid coverage. The first one is disability. So in children, this is only considering the child's income, not the family income. And disability, you have to qualify by proving that you have a disability to the Social Security Administration through essentially filling out what states typically call a functional screener, which screens for health problems and support needs that might indicate whether somebody has a qualifying disability and therefore cannot work. The other pathway to Medicaid for people with disabilities is income. So the way that somebody would qualify is by meeting their state's income threshold to qualify for Medicaid, and then also meeting the state's work requirements to qualify for Medicaid. Then there's the option of qualifying based on income and disability, which essentially means that you have to be a beneficiary of supplemental security income, which is for folks with qualifying disabilities who don't have a work history. And then you also have to meet income and asset requirements. So, in 2017, which I believe is when the latest data that I could find were available, Medicaid and the Children's Health Insurance Program, which is part of Medicaid, covered about 47% of children with special healthcare needs, which includes intellectual and developmental disabilities like autism. Medicaid, importantly, also through their long-term services and supports program, provide a broad range of both medical and long-term care services, which would not be otherwise covered through private insurance. And then Medicaid and CHIP can make coverage affordable and available to many children with disabilities and their families. So, for many people with intellectual and developmental disabilities, Medicaid is the only source of funds that are available to them to be able to live and work in their community with their friends and families and avoid more costly and segregated nursing homes or private institutions that are providing the care for them. So throughout the country, state and federal Medicaid together provide about 75% of the funding for services for people with intellectual and developmental disabilities. So it's a really key cornerstone to service access for people with IDD and for autistic people. And it's also extremely critical for folks who either can't work entirely or who don't have access to employer-based coverage or other private health insurance coverage, or who have greater medical needs, or who require assistance with activities of daily living throughout their lifetimes. And this program also covers over 10 million non-elderly people with disabilities, which I think is really important to think about in context. I really like this infographic that Dr. Shea's team put together, which talks about how the focus of covered Medicaid services may change throughout the lifespan. So in early childhood, For an autistic person, Medicaid may cover things like developmental and autism screening, diagnostic evaluation, and intervention services. And this, of course, changes throughout life so that once you hit adulthood, Medicaid is going to be essentially funding either long-term services and supports that support community living and or inpatient and outpatient physical and mental health care services, as well as behavioral health care services. And then when we think about aging and when we think about the later part of adulthood, Medicaid can also cover long-term services and supports, even though the focus of those long-term services and supports can change to focus more on care that you would provide to elderly folks rather than supports for community living. And we're also seeing Medicaid covering things like diagnostic and treatment of other health issues that are more prevalent among autistic people, such as Alzheimer's disease and related dementias and Parkinson's disease. It's also really important to think about the fact that some autistic folks are what we call dually eligible for Medicaid and Medicare. So for Medicaid, supplemental security income is typically linked with Medicaid eligibility. And for Social Security disability insurance, that is typically linked to Medicare eligibility. The core difference between SSI and SSDI is that folks who qualify for SSI don't have a work history, whereas folks who qualify for SSDI do have a work history. And that's in terms of their eligibility criteria. But also these programs work slightly differently. For instance, with Social Security disability insurance, there's a lag from when you qualify for SSDI and when your Medicare coverage kicks in. Whereas with SSI, Medicaid coverage kicks in as soon as you get access to SSI. For the folks who are dually eligible, this can look really different for different folks, how somebody becomes dually eligible. There's a nice infographic from Eric Rubenstein's group at BU that looks at how folks qualify for Medicaid and Medicare. And I put information about that citation on this slide also. But we also see some folks who are dually eligible because perhaps they're older adults and they qualify for Medicare as an older adult, but they don't have income or assets that can cover their health insurance. So for these folks, Medicare is the first payer, and then Medicaid is the payer of last resort. So things are first billed to Medicare, and then they're billed to Medicaid to cover out-of-pocket expenses. There are a lot of other ways that folks can be dually eligible too. But overall, we have about 10 million dually eligible people in the country, and then 56 million people who just have Medicaid and 40 million people who just have Medicare. These data are a little bit dated, but we are hoping to have some more updated data in the future.
Okay. So as we dig in on how these programs are used by autistic individuals in middle and older adulthood, so ages 40 and up, we can use data sources like billing data and enrollment data from the Medicaid and the Medicare systems to look at individuals enrolled over time. And we do see already that among individuals who only have an autism diagnosis or individuals who have an autism and an intellectual disability diagnosis, we have tens of thousands of middle and older adults who already rely upon these programs for getting through those doorways that Dr. Bishop described and getting access to needed services. Part of the nuance here is that Medicare, as a federal program, has a more consistent set of options across the nation, but that the Medicaid piece really is quite different across states. The individuals counted here could be enrolled in Medicaid waivers. They may be enrolled in Medicaid due to their income, and they may be enrolled in other new programs like 1115 waivers, which are creating new service options, sometimes merged with their Medicare services to try and help centralize care. We do see this number as stable, but I think to Dr. Bishop's point earlier, we will continue to see it rise as we see the increased number of individuals who have been diagnosed in the last few decades age. And so now is the time to prepare before this number grows and we then end up trying to meet unmet needs. We can start to prevent unmet needs if we start to think about these issues and track the volume of individuals right now. One of the other sources in which we can examine, so this is a state map actually using our national Medicaid and Medicare data. All of these data are from 2016, including the previous chart. And there are ways that this map is not all that surprising. We see lots of concentrations, higher numbers of individuals in states where there are higher numbers of people. Doesn't mean that there's something in the water in California or something special about their Medicaid or Medicare program that is definitely driving this difference. But it does point to ways in which we might need to think differently about state options, about resource allocation, and how some of those differences in Medicare as a federal program and Medicaid is a program that operates differently in California versus Florida versus Pennsylvania. And how can we learn from those differences to replicate what works and start to improve what doesn't? Next slide, please. Another option of a data source where we can look to understand the use of Medicaid and Medicare are all payer claims data. And these data are from the entire nation, and they include individuals who have many different kinds of insurance types. However, these data sets are not looking at individual people. Instead, these data sets are looking at the entirety or a simulated sample of inpatient stays or emergency department stays. So when you see proportions and numbers in this chart, those are stays or visits to an inpatient setting or an emergency department and not individual people. What's really helpful here, especially as we think about some of the Medicaid differences, we often stratify or differentiate how we look at these groups by autism or intellectual disability, because in particular in the Medicaid system, for decades, there has been an advocacy presence to create those doorways that Dr. Bishop described for the intellectual disability community that allow for an intellectual disability diagnosis to let people through that front door, to let people through the doorway. And that is not as true for autistic individuals, that this is a relatively new prevalence that we are seeking to understand in an increase. And that means that we have work to do, especially as we think about what is needed as these groups age. When we look at these inpatient stays, which are on the left, and the emergency department visits, which are on the right, you can see that by and large, Medicare is paying for these services. And that makes sense because one of the rules between Medicaid and Medicare is that Medicaid is the payer of last resort. That means that Medicare always has to pay if a person has both. But we do still see, especially when we think about how costly these visits can be, a tremendous amount of stays or visits to the emergency department that Medicaid is paying for. And there is a tremendous reduction in private insurance when we look at individuals who have an autism diagnosis versus those with an intellectual disability diagnosis versus the general population where private insurance is the primary payer because most of the population is working and has access to insurance through that source. Back to you, Dr. Bishop.
Yeah, so one of my former graduate student and Lindsay's current postdoc, actually Dr. Kylie McLean, wrote a really nice paper using some qualitative data that we collected in my lab and looked at applying, how we can think about barriers to high quality healthcare among autistic people to a multi-level theoretical framework that looks at barriers at the individual level as well as at the healthcare system and the broader system level. And I think really important to think about is that what the main findings were that, barriers to high quality healthcare included things like low levels of social support, limited knowledge on the part of healthcare professionals about autism, difficulties with things like the sensory environment, and length of appointments. So folks saying they needed more time in appointments, as well as not having access to things like online scheduling or communication with healthcare providers. But really important to what we're talking about today is that folks in our study who had access to health insurance through Medicaid and Medicare felt as though they had relatively good access to being able to see doctors and go to doctors without having to pay massive out-of-pocket costs. And in some cases felt as though they were more able to receive comprehensive wraparound care because they were covered by Medicaid. Sorry, my slides keep jumping around, and I apologize about that. So, what could we do to improve the healthcare system for adults who have autism diagnoses? We could increase the length of appointment times. We could train providers in how to support autistic adults in their practices. We could ensure online options for appointment management and communication. We can create tools for autistic adults to communicate their needs in non-normative ways, such as using nonverbal communication to communicate needs. And we can also do things like to reduce the sensory overwhelm of healthcare environments, such as having sensory rooms with minimal lights and noise. And then I think really importantly too is accessible transportation for autistic people. We've also been doing some work recently using national Medicare data where we're trying to better understand whether autistic people experience disparities in end-of-life care. I want to first say that Medicare qualifies or covers hospice care for all Medicare beneficiaries at 100% for the first set number of days of hospice care. So I think the fact that this is a universal benefit that's available to everybody and that it's a no-cost benefit through Medicare is important as we think about the context of these findings. So, what we wanted to do in the study is we wanted to compare the hospice utilization of autistic older adults to non-autistic older adults. And I should also just say really quickly that hospice care is end-of-life care. So it's care that is delivered once folks they have a diagnosis that will lead to long-term disability or long-term issues with not being able to survive. So they therefore can opt into hospice care, which is supportive care at the end of life. Given what we know about health disparities among autistic people and that autistic people experience many more health disparities, we wanted to examine if known inequalities in hospice utilization in the general population were exacerbated among autistic older adults. We had a sample of a little bit over 5,000 autistic older adults who we matched to a sample of a little bit over 10,000 population comparison adults. And we utilized multivariate logistic regression to compare the odds of receiving hospice at any point or receiving hospice early in the middle, right? So right when we would expect somebody to receive hospice or later. And then we looked at whether the Medicare beneficiaries' sex, race, or whether they lived in a rural environment affected their access to hospice care. And I think interestingly, so these plots, because all of the horizontal bars are crossing the dotted vertical bar, what this tells us is that there aren't any significant differences between autistic people and non-autistic people in terms of whether they've ever received hospice services or whether these hospice services came early at an intermediate level or late, which tells us that universal no-cost benefits really have the power to reduce disparities. And they seem to have done this for autistic adults who were Medicare beneficiaries and received hospice before the end of their life.
Okay. So one way that we can start to think about why do Medicaid and Medicare matter? Hospice programming, obviously, is a key support and a key service for thinking about end of life and in what ways we can consider differences. We also have partners through the University of North Carolina in one of our projects who are thinking about the concept of aging well and how can we proactively try and identify components of aging well that we can seek to support to try and build upon the ideas of thriving and flourishing in ways that we all seek to be well as we age. So this is work from Dr. Klinger and Claire Klein at the University of North Carolina that we've partnered on for some of our work in our Advancing the System of Care for Autistic Older Adults project. And there are a few elements of aging well that Drs. Klinger and Claire Klein have highlighted here. So there's healthy aging, thinking about activities of daily living and health. And then there's active aging that has a separate set of components in the cognitive and physical functioning, as well as positive affect and control domains, and productive aging, an area where we think about social participation and engagement. Next slide, please. And so focusing on health and activities of daily living, we have used some of our data as well as some of the reports directly from autistic older adults to understand chronic conditions, experiences related to menopause, and how trajectories of daily living skills feel and work for them as they're aging. Next slide, please. Thank you. So we sought to look at some of our combined data related to chronic conditions. In chronic conditions, we have a set of validated algorithms that are produced by the Centers for Medicare and Medicaid Services that tell us how to find these conditions. They tell us which diagnosis codes to look for, in what ways. And when we apply those to our years of Medicare and Medicaid data, we can see that many individuals, the highest proportion of individuals who have an autism diagnosis with or without a co-occurring intellectual disability, have 5 or more chronic conditions in the aging past the age of 40, which indicates that these systems, that Medicaid and Medicare, are key to managing not just one condition and thinking about how just one diagnosis looks or proceeds over the aging process, but also how we look at core services like even hospice and some of the medical care that individuals need to access alongside behavioral health supports and other kinds of supports for their everyday life. Next slide, please. And many of these chronic conditions sound very familiar to all of us who are aging. Conditions like high rates of hypertension, hyperlipidemia, we see high rates of depression, and this is across both older autistic adults who have an intellectual disability diagnosis as well as those who do not. And generally, these conditions cluster in some areas that we have specific concerns about how we're going to manage these conditions over time, especially as they co-occur together. We can see these conditions many times happening in the same person. So it's not just one set of medical needs alongside behavioral health needs, but often many healthcare needs that even those of us in the general population have challenges to navigate successfully across medications and access to doctors and all of the places where we need to be to get the care that we need. Next slide. So as we think about what we can do, we know in the public health and the clinical domains that there are ways that health communication is really important, that there are specific sets of dynamics related to how we interact with doctors, how something rises to the top of, this is really a problem for me and I'm feeling something and I need help figuring out to identify what it is and how we're going to manage it and how we're going to make it feel well. And other times things aren't felt as much and are detected through other healthcare processes. And so all of these make the ways in which we set up key programs like Medicaid and Medicare all the more important so that they can help doctors and be available for services needed among autistic adults as they age. Next slide, please. We've also engaged with a set of middle and older autistic adults from both the University of North Carolina, the TEACH program, which the University of North Carolina has been working with and following for decades, as well as a newer sample that we have recruited in Pennsylvania, initially for a statewide needs assessment survey from the Pennsylvania Medicaid rolls and other community-based sampling too. This sample aligns with some of the characteristics of our states, but there are some ways in which we suspect it does not fully represent the US population. And there are certainly ways that we can use this as initial information to highlight where we need to look further and in what ways we need to look further, but would certainly note that this is likely not a comprehensive examination of autistic older adults in the sense that we can really derive national Medicaid and Medicare strategies from it. And so as we asked individuals about their unmet service needs, when we said, what do you need? What are you not getting, but you need more of? What are you getting, but you need more of? And what are you not yet getting and need? There were several sets of services that really rose to the top. So daily living skills, navigating life, navigating all the things that we all need to do every day to get out the door, to get out of bed, and to get through the things that are required in our everyday lives. Behavioral services, and this is also reports from autistic older adults and caregivers or care partners. So ways in which individuals may need to be managing aspects of their lives where they need one-to-one support or other types of therapeutic interventions. We also, even among autistic older adults, continue to see needs for things like speech and language therapy that are services that we've often thought about and examined in younger children, but likely have a continued aspect of how we support individuals as they age. We also have, as Dr. Bishop has been seeking to understand mental health care needs across a lifespan, that although we don't yet have comprehensive data to really track the adult and older adult experiences in the mental health front, there likely is a lot here that we need to uncover. And it's going to take a tremendous amount of research and understanding and partnership with autistic older adults and their care partners to be able to understand these needs. Some of our data sources will tell us some things, but often we need to combine them in order to really get an understanding. And case management, that key component of helping to pull it all together. Who is getting called when and where do you go next? And that this is often an overlooked aspect of services, but is a key area, as Dr. Bishop indicated, where service entirety, so the entirety of the Medicaid and the Medicare program can step in to help be a resource for case management, where there can be centralized source of records and follow-up so that we can help ease these processes. And it's not just all about keeping that Post-it note next to your telephone and a pen so that you're ready when the next call comes in to figure out the next step. We also sought to examine these responses across individuals who might be living alone, living in the community with a partner or a roommate, living with families or guardians, or living in supported living facilities. And we continue to see some variation in what people are needing across these settings. So for example, living alone, individuals had high rates of indicating that they needed mental health and behavioral health services, but closely aligned with the proportions that we also see in case management, daily living skills. All of those reached about 1 in 3 individuals and about 1 in 5 indicating employment support needs. Individuals who are living with family or other guardians also indicated high rates of behavioral support needs, activities and daily living skills, speech therapy, almost 1 in 3, also support for caregivers and mental health services. And even when individuals are in supported living facilities where there are concentrations of providers and presumed service access, there are still big gaps for up to 1 in 4 in getting services like those for supporting daily living skills.
Okay, sorry about that. I was having a hard time getting mute to come off. But so, what services and supports can help encourage healthy aging among autistic people? So I think for all of us as we're getting older, social supports are incredibly important. So inclusion and social, recreational, and leisure activities. We also, in many autistic people, need to think about care transitions after parents die. I think that all of us, regardless of whether or not we are autistic, need some level of support as we age and as we begin to access more healthcare. I think it's very normative to receive support, regardless of whether you have an autism diagnosis or not. And for many autistic people, parents are the primary supporters in healthcare settings. So transitioning care to another loved one or family member or friend, or perhaps a spouse or an adult child may be very helpful. Autistic people also may benefit from independent living, family living, or nursing home care, depending on their level of healthcare needs. And, for health, we think that preventive and routine healthcare is incredibly important to support healthy aging among autistic people. As all of us know we all need to be active, and adults with intellectual and developmental disabilities, including autistic adults, need to be active like all adults. We also, and I would argue that we don't have really great data on this yet, and we can't definitively say whether autistic people experience early aging or accelerated aging, or whether they age at a similar pace to non-autistic people. But one of the leading theories in the field is that there may be some autistic people for whom aging is early or accelerated, or which would essentially mean that some health problems would start earlier and perhaps increase in severity more rapidly. Once we have more comprehensive data on this, we'll be able to determine whether any of these conditions necessitate early screening or early intervention to improve healthy aging. And then I think very important to this talk, access to Medicaid and Medicare benefits, plus expanded uptake of ABLE accounts, which we'll talk about in a little bit, are incredibly important. So how can we reimagine the policy landscape to reduce disparities in autistic people? So, I think one thing that's really important is that the asset limit for SSI and SSDI is $2,000. And this asset limit has not increased in many, many years. Increasing the asset limit, I think, would be very beneficial to helping more people qualify for SSI and SSDI, while being able to have enough funds saved in case they have an emergency and need to cover that with funds that are greater than $2,000. Another big issue that we all know is that there is not equitable geographic access to providers. So folks who live in more rural areas or in super rural areas have much poorer access overall to providers than folks who live in suburban or in urban areas that are higher socioeconomic status urban areas. I think it's also very important to educate providers about autism and intellectual and developmental disabilities and their care needs. In terms of policy, I think that, the adage, nothing about us without us, is incredibly important when we're thinking about policy and policy reform. And we should be including autistic people and people with intellectual and developmental disabilities in all policy planning and implementation planning discussions. ABLE accounts are also incredibly important, and less than 1% of eligible folks who could qualify to be able to use an ABLE account, which allows somebody to save money in a protected way to cover expenses that will not count against their eligibility for SSI or SSDI. Expanding access to these accounts and uptake of these accounts is incredibly important. Also really important is to increase the reimbursement rates for providers and direct care workers, which, will both have the benefit of increasing the number of care providers who are serving Medicare and Medicaid beneficiaries, but will also encourage folks to live in more rural areas or in states where reimbursement rates are a lot lower. I think providing funding for health navigator or case management programs is also incredibly important, and something that Dr. Shea's data really speaks to. And also importantly, maintaining the current Medicaid funding structure and not changing the funding structure to reduce the overall cost of the program. So the Affordable Care Act did expand Medicaid coverage to most adults with incomes of up to 138% of the federal poverty level. So in 2023, that was a little bit over $20,000 a year for an individual. However, not all states expanded Medicaid under the Affordable Care Act, and therefore everybody in the country is not going to benefit from this. And it provided states with a 90% enhanced federal matching rate for their expansion populations. And, importantly, a comprehensive review found that the expansion would help to expand coverage and reduce the number of people who are uninsured. It would improve access to and utilization of care. It would reduce uncompensated care costs. It would improve care affordability, and it would reduce racial and ethnic disparities in care coverage. So, currently, most states in the United States have adopted the expansion and implemented it. but there are still some states there that are displayed in orange that have not adopted the Medicaid expansion, and some states that have adopted but not implemented the Medicaid expansion. So ABLE accounts are achieving a better life experience accounts that were authorized through the Achieving a Better Life Experience Act to create tax advantage savings accounts for some people with disabilities that began in childhood and their families. For autistic people, autism does count as a disability that begins in childhood, even if an individual is diagnosed as an adult, because it's a developmental disability, meaning it starts during the developmental period. So even somebody with an adult diagnosis could qualify for an ABLE account, given that this is a disability that started in childhood. So these accounts allow for more individual choice and control over spending, while protecting eligibility for Medicaid, SSI, and other federal benefits. The funds in these accounts, and you can save in these accounts up to $100,000. You can invest in an ABLE account in any state that has an ABLE account within their system, regardless of whether you live in that state. Can be used for a variety of purposes, including education, housing, transportation, employment training and support, assistive technology, personal support services, healthcare expenses, etc. As I mentioned previously, less than 1% of folks who are eligible for ABLE accounts have ABLE accounts, but increased uptake of these accounts would allow for folks to be able to save additional funds that go beyond what they're able to save to qualify for SSI and SSDI. So for many years, there have been policy proposals to begin to block grant Medicaid. So block granting means that states have a preset amount of funding based on how much they spent in the previous year. So for 2024, that would be 2023 spending. And each individual that was part of Medicaid in 2023 would be given funding as part of the block grant. But what it doesn't do is it doesn't account for the fact that more people use Medicaid every year, typically. So it will then overall reduce the amount of money available to each individual Medicaid beneficiary in the state. Per capita caps are when the federal government sets a limit on state reimbursement per enrollee. So restructuring the funding of Medicaid would force states to lose federal funding and have to make difficult decisions to cut optional Medicaid services that are not required by the federal government, or to cut who can qualify for Medicaid in the state to ensure that all beneficiaries are provided their mandatory care. Autistic people could also lose access to home and community-based services, and states may have to increase their use of institutionalization. And this means that the needs of people with disabilities must be considered in any proposal to restructure Medicaid. So, if a state wants to add more enrollees, add more services, cover new prescriptions, or increase provider reimbursement, that would be possible under the current structure of Medicaid. It would not be possible under block grants. But if we went to a system with per capita caps, the number of enrollees could be increased, although the more services, new prescriptions, and provider reimbursement could not be increased. So one thing that I also want to mention really quickly is that if you have supplemental security income or Social Security disability insurance, and/or you receive Medicaid or Medicare benefits, study participation, being on an advisory board or receiving consulting payments as a co-researcher may impact your benefits either alone, if that's your only earned income, or along with other earned income. So for folks who have SSI and Medicaid, if you have an earned income greater than $85 per month, the income will reduce your SSI payments in subsequent months by $1 for every $2 you've earned. If you have SSDI and Medicare and are younger than 65, if you earn in a single month an income of a little bit over $1,000, this triggers a trial work period. And earned income over $1,550 counts as substantial gainful activity, which would then disqualify you from benefits. And what may happen to some folks who were SSDI and Medicare beneficiaries who earn enough income to kick in a trial work period and then incur substantial gainful activity, if they lose their SSDI and Medicare coverage, but then later are still working but need access to health insurance, they may qualify for Medicaid, but it's a really complicated process to requalify and to qualify for a new program.
I think Dr. Bishop's point earlier about needing a PhD to navigate all of this, even for those of us who have doctoral degrees in these areas, it is still so very complicated. So our goal for these last few moments is to highlight a few resources that can help you start to get to an understanding and perhaps digest this in your own time and get to local resources. Part of the issue, especially on the Medicaid front, is that since states work differently, you really need to engage with people who know the system in your state and sometimes even in your city, in your locality, to get where you need to go. The Kaiser Family Foundation has a resource for people with disabilities, families, and advocates on navigating Medicaid and Medicare. It's from many years ago, from the early 2000s, but I think some of the core components, as those that Dr. Bishop has covered, in some ways sadly remain functions of how the systems work and can help be a foundational guide to how you think about these two Medi-Whats. We have a few other resources here. I think that the Spark folks will be highlighting in links and through a resource guide available to all of you after the webinar too. Thank you all so much. And thank you, Dr. Bishop, for having me here on this webinar with you. I learn every time.
Likewise, I think Dr. Shea and I collaborate together a lot, but we always learn from each other whenever we present together or work together, which is one of the really fun things about science.
I think that was a perfect way to put it. It's always fun to, even though you're in this research and in this world, you can still learn something new all the time. And yes, to your point, Dr. Shea, I will be sharing additional resources. They will appear on the Spark website alongside the webinar recording, as well as a copy of these slides. So you can look out for that in the next few days if you're an attendee. But we do have a few minutes, so maybe we can get to a couple questions. I did see that both Dr. Shea and Dr. Bishop were responding to some questions as they were able during the presentation. So thank you both for that. So I will just ask a couple things, and yeah, we'll do what we can in the next 5 minutes. So, or is there a general approach to appealing a denial for either Medicaid or Medicare, or recommendation?
So I think one thing that I'll say is that the vast majority of people have to apply more than once and have to appeal a denial. So I think it's in the vast majority of cases worthwhile to appeal a denial. How you do that and the specific way that it functions will vary by state, especially if it's Medicaid and SSI. But so, and a lot of this has to do with the functional screener, and the way that the functional screeners work in most states is that it's a algorithm-based kind of thing where an individual comes in, asks questions, and puts it into a program that will then turn out whether somebody will qualify based on the results of the functional screener. So this is something that it's worthwhile overall to appeal if you're denied, because denials often happen before people end up qualifying. I don't know if, Lindsay, if you have anything else to add.
No, again, learning from you all the time, Dr. Bishop. I think these things are so complex to navigate. I think I would not add.
Yeah, and one other thing I will say is that all of these states create functional screeners. They don't always utilize disability experts when they're creating functional screeners. Sometimes they're experts in other academic areas. I've anecdotally heard about functional screeners being created by child welfare experts who have no expertise in disability. So they really vary, and there's a lot of variability. And, what they're trying to do is, from a policy perspective, ensure that everybody who qualifies has an actual disability. But what the state counts as a quote unquote actual disability can really vary, and it can be somewhat punitive because they're, again, trying to save money in their broader Medicaid programs.
Thank you. And this question came in from quite a few people, and I believe you might have touched on this, but I think it's worth reiterating because it was asked. will an individual have access to SSDI if their parents work, but not necessarily they themselves as the autistic person?
I've heard that you can, if you are in the same household, that working quarters for your parent can be counted for your SSDI eligibility process. I am not clear on if there is an exception process that is needed to be able to request that, or if an extra layer, like an attorney, is needed to help file extra paperwork to make that happen. Have you heard that as well?
I have heard that, but it's only anecdotal from folks. And I think there's some context to it also, right? Like when the parent with the work history passes away, I'm popping something in the chat that's a Centers for Medicaid and Medicare Services document on dual eligible people with disabilities, which I think goes into this a little bit, but it's a policy document and it's kind of complicated. It's certainly not user-friendly.
Okay, I guess we have time for maybe one more question. So in your earlier slides, you covered, the different pathways for people to be able to qualify for Medicaid. And you made a point to say that that was kind of geared more toward children versus older adults. And can you define what is meant by children in that context? Is that just people under 18, or can they, if they're fully dependent, perhaps, but older?
Yeah, so the age cutoffs for when you're considered to be an adult and considered to be part of the adult services system, they vary by service, right? So special education can go through age 22. Medicaid, in the context of Medicaid and Medicare, it's after age 18. That said, there are some differences when you're between the ages of 18 and 22 in the qualification process, especially if you're still enrolled in special education settings. So at least from a research perspective, we generally look at folks who are 22 and older when we're talking about adults and we're using Medicaid data, because it's just a little bit cleaner and more consistent nationally. And also keep in mind that many folks need to start applying for SSI or SSDI before they hit adulthood. So it may be appropriate for some teenagers to be starting the application and qualification process, especially if they'll need long-term services and supports in adolescence.